The appropriate dosing, 1, 2, 3, or 4 puffs as ordered by the physician ordered, and it's returned to the med dispense. Appropriate instructions for the metered dose inhaler, we want to make sure that the MDI is shaken. So as you're bringing it from your nursing station, from the med dispense to the patient's room, just shake it up on your way there. This device can only be put together one way. It can't be put together any way but this. Okay, so we're shaking it up on the way to the patient's room. The spacer or aero chamber is going to be left in the patient's room, obviously. But once we get there, we're going to shake it up. The patient needs to take a slow, deep breath on the mouthpiece with a good seal. Slow, deep breath. Hold your breath for approximately 6 to 10 seconds and then relax. And so if there are consecutive puffs ordered, 2 or 4 puffs, in the meantime we want to wait approximately 1 minute in between puffs. Continue to shake it up so that it's not settling during that 1 minute, and actuate additional puffs into the aero chamber. There should never be more than 1 puff at a time actuated into the aero chamber. We don't stack puffs because we want to make sure we're getting accurate medication with each puff. Not 1 really good puff and then 2 or 3 substandard puffs. So 1 puff at a time into the aero chamber. If the patient makes the aero chamber whistle with their inhalation, they are taking too quick of a breath, and so we're going to close off our airways faster, and so we want them to slow down. Take slower, deeper breaths so that we're not making it whistle. That's an inappropriate instruction. Metered dose inhaler. Also with the metered dose inhaler, make sure that an order is sent to the cardiopulmonary department so that we know to come and do that initial instruction for the MDIs, to include Advair, Spiriva. We do the MDI initial instructions for those as well. The handheld nebulizer. This is the correct configuration for this device. It can go together in different ways. However, if it's not a snug fit, it's not correct. And so this is the correct way. We also have masks, face masks for this device, for individuals, for our patients, for our clients who cannot utilize the mouthpiece. For example, if they're still groggy from anesthesia, or level of consciousness is such that they can't use the mouthpiece. And so we have face masks also that we can use with this device, to include pediatric size face masks. Again, this is the correct configuration for this device. It can go together different ways, but if it's not a snug fit, it is incorrect. O2 delivery devices. The nasal cannula. We have 3 sizes for the nasal cannula. The adult size, the pediatric size, and the neonate size. It's important to use the correct size for our patients to deliver appropriate oxygen. The holes in the diameter of the adult mask is far too large for a baby. So make sure that we're picking up the correct size for the nasal cannula. Appropriate flow for the nasal cannula for the neonates is 0.1 to 1 liter per minute. For the adult size, 1 liter to 6 liters per minute. This is not a device for 10 liters or more per minute. So if we need more oxygen, what the nasal cannula can deliver, then we need to switch to a different device. But we need more than, for example, 24% to 30% oxygen, the nasal cannula is not what we're going to use. Again, 1 to 6 liters per minute. If we need more oxygen delivery, we can use a simple mask. The simple mask is going to provide approximately 45% oxygen. With the mask, a minimum of 5 liters per minute or 6 liters per minute for the babies, up to approximately 8 to 10 liters is what we're going to use for a mask. If you have the mask on the patient and you have flow going, but you see condensation in the mask, we don't have enough flow, and so therefore we need to turn the flow up for our patients. Again, with this mask, with the simple mask, we want to be at least 5 to 8 liters per minute, minimum. If we need more oxygen than that, and also for our COPD patients that have a different O2 demand, we're going to we can move to a Venturi mask. This mask allows us the possibility of titrating O2, weaning O2 down for our patients. The Venturi mask is the only mask that we have where the flow can go below as low as 4 liters per minute. To know what the appropriate liters per minute in FiO2 is for your mask, look on the bottom of the adapter, look on the bottom, and it will tell you exactly how many liters per minute and what your FiO2 is going to be. Do not throw this bag of adapters away, because then we have no possibility of weaning with the Venturi mask. This is the correct setup for the Venturi mask. So all parts are necessary. The mask, the corrugated tubing, the adapter with the entrainment device underneath it, and our tubing. So nothing gets thrown away. And so we have a possibility of an even higher O2 demand. We're going to switch to our non-rebreather. It has a disc on the side. Sometimes you may see a second disc on the other side. This mask is the only one that we have that can provide up to 100% FiO2. When we're going to use this mask, if we place our finger over the valve and plug it into the oxygen, we're going to inflate this bag and then put it on the patient, and so therefore then the patient has oxygen immediately when we put it on their face instead of waiting for this to fill up. This mask should go between 12 to 15 liters per minute or flush on the flow meter. If the patient is breathing on this mask and they're collapsing the bag completely, they don't have enough flow, and so therefore we need to turn the flow meter higher. So if we're starting at 10, then we need to increase to 12 or 15 or flush, depending on where we initially started. They should not completely collapse this bag with their respirations. Okay? So 100% FiO2, up to 100% FiO2 with the non-rebreather. Also with the nasal cannula for humidification. With the babies on oxygen, regardless of the flow, whether it be 0.2 liters per minute or 4 liters per minute, we're going to put a humidification bottle on the oxygen device for the babies, for the pediatrics, not just for the babies, for the pediatrics, for the children. With the adults, the standard is 4 liters per minute or more for humidification. However, there has been the occasion if they're on the nasal cannula continuously, even 2 liters per minute can drive the nasal mucosa out, and so we will also put humidification on the nasal cannula for the adults at 2 liters per minute. However, the standard is 4 liters per minute, and then it's required. Some other O2 devices are the face tent. This one is primarily used by our recovery staff in the OR to wake up patients coming out of anesthesia And also if they've had a facial surgery or something of this nature where we're not going to have a nasocania there, but we want to wake them up. We're also going to hook this up to humidification, and it's only going to be approximately 45% FiO2. This is not a high flow FiO2 device. This is only approximately up to 45%. So that's our face tent. Also, we can deliver oxygen to the babies with our mist tents, or also our care cubes. They come in 3 sizes. We have the very small for just the head of the infant with a newborn. We have the medium size, the middle size that can go over a larger baby, or we have the large size that can also go over a car seat, a standard car seat for the larger children. This has replaced our mist tent. Some people refer to this as the mist tent. This is what we can use this also with just compressed air, the yellow flame meter, or with a delivered FiO2 and humidification. Again, because with the pediatrics, we're always going to have humidification. As with the face masks, in the mist tent, in the care cubes, if there is too much condensation in the care cube, we don't have enough flow for the care cube, and so we also want to set that at least above 10 liters per minute and higher if it's necessary. We also want to make sure that we're checking the babies to make sure they're not too wet in the care cubes. We don't want them to be wet in the care cube, and make sure that we are checking the FiO2 that's delivered in those care tubes and make sure we have appropriate flow in there. When we are dealing with aerosol delivery of oxygen or just humidified air for possibly babies with croup or stridor, and we're using humidification bottles, delivered FiO2 is not just dependent on the flow from the flow meter. It is also determined by the blue dial on the cap of the bottle. So what we're going to chart, what we want to chart for this is what's delivered here. For example, this is set at 40% and 10 liters per minute or more on the flow meter. It's not just 10 liters per minute. It's what's delivered on what's turned on your dial and what is set for liters per minute. If this is on a yellow flow meter, there is no FiO2 delivered. There is no oxygen delivery on the yellow flow meter. We are just giving humidified air at that point. And so do not chart that you have an FiO2 of 30%, because that's where you see the cap set. If it's on a yellow flow meter, there is no oxygen delivery. It is just humidified air. That ends the O2 tank safety and the respiratory equipment portion of the nursing skills day.
And now